Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy! Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Willow University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we round out our discussion on colorectal cancer, this time focusing and continuing rather our discussion on metastatic colorectal cancer and focusing a little bit more on colorectal cancer with certain genetic changes. And we'll talk about what that means a little bit more and how that has implications on treatment. But guys, I'm excited to wrap up this series. I think it's been a great series. I certainly have learned a lot. How are y'all feeling?
Yeah, really excited to get into this one. You know, this is an episode about treating smarter instead of harder. And so really excited to get into the data.
Yeah, always love talking about targeted therapies. Let's get into it.
Sounds good. Let's roll that show. Before we get started, I just want to point out that this is the last episode that we will all record being in the same city. Even though we don't record our podcast in the same room, we are still within a drivable distance of each other. And the next time we'll be doing this, I'm going to be a lot further away and in a different time zone. So guys, it's been real.
Yeah, it's crazy. It's sad to see you leave, but we're really excited for you to be up there in Philly and, start your new job at Penn. It's going to be a good time. So we're really happy for you.
Yeah, definitely looking forward to crashing at your beautiful new house. That's going to be fantastic. And I feel like we need a clickbait thumbnail for the post this week in Ronak's last episode.
We can work on that since I'm the one that makes said thumbnails. But, this is incredibly bittersweet. It's been a great time here in Nashville. But, because of the nature of our show, Willow University will live on. And so I'm excited to keep this tradition going now just in two different cities. So we're branching out. We're expanding our reach, Willow University. But guys, with that, let's move to our final episode of the metastatic colorectal cancer discussion that we started last week. So Vivek, do you want to start us off with the case?
Yeah, so same case as last time. We have a 56-year-old female who presents for management discussion of her newly diagnosed metastatic colon cancer. Long story short, I'm just going to get to the details of the biopsy. Remember from last time, she had a CT that showed multiple bulky hepatic metastases in bilateral lobes, a right adrenal mass, and multiple peritoneal implants that were concerning for metastatic disease, in addition to a primary left-sided tumor. She underwent a CT-guided biopsy of the hepatic mass, which showed a poorly differentiated colon adenocarcinoma that was MSI high and HER2 negative by IHC. Next-generation sequencing showed that she was BRAF wild type, KRAS wild type, and NRAS wild type, and her CEA was elevated at 250. So as we discussed last week, we need to first really determine if our patients have resectable oligometastatic disease that could be treated with curative intent or have more widely metastatic disease that would be treated with palliative intent. And we also need to know the MSI status, HER2 status, BRAF status, and RAS status for our patients to plan treatment. And check out the episode last week where we really get into the nitty-gritty details for our general patients with colorectal cancer. But now we want to focus on the subgroup of patients who have MSI high or HER2 positive or BRAF positive tumors. So in this case, our patient has an MSI high tumor. What's the data for the use of immunotherapy in these patients, given that we have these great studies in the rectal cancer space with dostarlimab showing that 100% clinical response rate in rectal tumors? What's the data for metastatic disease?
MMR and MSI testing is going to be super important for any patient with colorectal cancer, as we previously discussed in our prior episodes. And you can check out our intro episode to the series for a little deeper dive. But the reason that we want to know about this MMR and MSI status in the metastatic setting is they're critical predictive markers for response to a very important class of therapies, immunotherapy. And so the incidence of these MMR deficient tumors has been looked at in a variety of different studies. There's a big pooled analysis of patient data from 4 randomized trials looking at over 3,000 patients with metastatic disease. That was published back 10 years ago now, 2014. And it showed the incidence of MMR deficient tumors was about 5%. We'll have a link to that in our show notes. And so again, the relevance here, we know that these tumors seem to be more immunogenic, and therefore they're predictive of a response to immune therapy. And immunotherapy was first evaluated in the second or later lines in these patients after treatment with FOLFOX, FOLFIRI, or both. And the Keynote 164 trial looked at pembrolizumab. Remember, keynotes are going to be looking at the pembrolizumab efficacy. And that was pembro monotherapy. And it was found to have an overall response rate of about 33%, with a median progression-free survival of 4 months. The Checkmate 142 trial looked at both nivolumab monotherapy and ipilimumab nivolumab combination therapy. So remember, checkmates are going to be on that Nivo or Ipi-Nivo spectrum. The overall response rate for Nivo monotherapy was a little over 30%, with a 3-month disease control rate of 70%. The overall response rate for the combination therapy with Ipi-Nivo was 55%, with a 3-month disease control rate of 80%. Both of these studies led to approval of immunotherapy in the later lines of treatment. But as we know in oncology, if it works in a later line, then we try and see if it's helpful to use it earlier. And so there's a pivotal study, the Keynote 177 trial, that ended up leading to the approval of pembrolizumab in the first-line setting. That was a group of over 300 patients who were randomized either to chemotherapy plus minus bevacizumab or cetuximab versus pembrolizumab monotherapy. The original study was published in New England Journal in 2020, and it showed a significant progression-free survival benefit. But longer-term follow-up was actually just presented at ESMO 2023, and it showed both a PFS and overall survival benefit favoring the immunotherapy arm. It's important to note that the overall survival curves favored chemotherapy slightly initially and then cross later on to favor immunotherapy after around the 8-month mark. And that suggests that patients with higher tumor burden may need chemotherapy first. Maybe there's some benefit from kind of debulking some of that larger quantity of disease before you move to the immune therapy side. The 5-year overall survival was about 55% with immunotherapy compared to 44% with chemotherapy alone. So 10% absolute increase in survival. The PFS at 5 years is 34% compared to 7%. So much sort of more striking difference there. If patients did respond to immunotherapy, then roughly 70% of those patients had durable response up to 5 years out. And most importantly, there was a health-related quality of life analysis that led to a clinically meaningful improvement in the immunotherapy arm compared with chemotherapy. And we'll have links to that trial in our show notes as well.
And Dan, I think this really is important for our patients, right? So in this study, we had pembrolizumab in the frontline setting, and we found there was an overall survival benefit. And as we've been talking here, when you're thinking about overall survival, you want to make sure that the patients who got chemotherapy first crossed over and got immunotherapy in the second line setting. Crossover is not a bad thing. It's what we need to do if it's approved in later lines. And in this study, there was about 60% of patients who ended up in the second line receiving immunotherapy. So we'd like to see that be 80 to 100% of patients, right? Ideally, really 100% of patients, but really, we know that some patients have a poor outcome or have rapid disease progression and can't get it. And, 60% is lower than we want. Even with that, though, let's hypothetically say that the overall survival benefits washed out if you get immunotherapy in the second line. The thing that's striking to me the most is what you said with this health-related quality of life, and that's huge, right? If that's going to benefit our patients, I think that's really, really big. So, Ronak, what about the data for combined Ipi-Nivo? If we saw that there was more response rates in the second or later line settings compared to Nivo alone, or what are we seeing in the frontline setting?
So we have data for Ipi-Nivo in the frontline setting, as you're alluding to, and this comes from the Checkmate HW trial, where patients were randomized 2:1 to receive Nivo monotherapy versus Ipi-Nivo or chemotherapy alone. And so we knew from later line data that Ipi-Nivo had higher response rates, so the thought was that it might lead to improved survival in the first line metastatic setting. This is not an uncommon thing that we talk about on this show. So essentially, patients got 4 cycles of combined Ipi-Nivo followed by Nivo monotherapy every 4 weeks. And the results of Ipi-Nivo versus chemotherapy were presented as a late-breaking abstract at ASCO GI 2024, so just a few months ago. The 2-year progression-free survival in the Ipi-Nivo arm was 72% versus only 14% in the chemotherapy arm. And the PFS2 was also significantly improved in the Ipi-Nivo arm compared to chemotherapy, though it's unclear how many patients crossed over into the immunotherapy, which could significantly impact these results. At the data cutoff, about 20% of patients were still on treatment in the Ipi-Nivo arm, which is good. Longer-term follow-up is needed, and Nivo monotherapy data will also be helpful, but results of the study are very promising. And so what we're seeing is that combination immunotherapy should be considered for fit patients with metastatic MSI-high disease.
I think this study is really important, and it shows, we have Ipi-Nivo combinations now neoadjuvantly in melanoma, right? That data was a plenary session at ASCO now in 2024. And Ipi-Nivo for these patients really does seem to be beneficial. The big thing in the future is we need to be able to identify the patients who are going to respond to immunotherapy, right? If they respond, they do really well for the most part. And we really need to tease out, there's more to this than being just MMR deficient and MSI high. How can we predict the patients who will respond best to this? And when and where should we use chemotherapy for these patients? So our patient was started on first-line Ipi-Nivo. She was a fit patient and tolerated therapy well other than a grade 2 dermatitis and grade 2 colitis, which have since resolved with steroid therapy, and she's now continuing on Nivo monotherapy and doing quite well. So let's switch up the case now. Let's talk about a different targeted case. What if this same patient was not MSI high and had a BRAF V600E mutation found on NGS?
I wish I could say it's as great of a story as the immunotherapy story. Well, no spoilers though. Basically, currently, first-line therapy is still either going to be FOLFOX or FOLFIRI, with or without bevacizumab, and 5-FU maintenance, as we talked about in detail in our first metastatic episode last week. It's important to know that roughly 5 to 8% of metastatic patients do have BRAF mutated disease on that same pooled analysis of trials that we discussed earlier, and about a third of patients with MSI high tumors will also have a BRAF mutation. These patients also tend to have right-sided tumors and generally have a poor prognosis with a kind of aggressive tumor biology. We had BRAF and MEK inhibitors approved in melanoma previously, so the thought was, why not treat our patients who have BRAF mutated colon cancer with these same drugs? BRAF inhibitor monotherapy did not work well, with response rates in the neighborhood of 5% in the early phase studies for these patients. There was a pivotal paper published in 2012 in Nature that showed that BRAF inhibition led to an overactivation of the MAP kinase pathway through EGFR signaling, and that dual inhibition with both BRAF and EGFR inhibitors might be more effective. So there was a phase 1b study looking at the BRAF inhibitor encorafenib combined with cetuximab, and that had a little bit more promising results in response rates of about 20% in a pretty heavily pretreated population.
And I think that's really interesting, right? We talked about it last week that if you have a RAS mutation, upstream of that is EGFR. So if you try an EGFR inhibitor there, it doesn't matter because it's constitutively activated downstream from the EGFR signaling pathway. And what's interesting here that Dan said was, well, if you have a BRAF mutation and block that, then the body's naturally like, let's upregulate the crap out of EGFR. And so now we have to block both pathways, which is very, very interesting. So now we have a phase 3 trial. Can you go through some of the data about what led to the approval of BRAF agents in the second line for these patients?
Yeah, so then we have that pivotal phase 3 Beacon trial that led to the actual approval of encorafenib and cetuximab in the second line setting. So patients in this study had all received either 1 or 2 prior treatments. They were randomized 1:1 to encorafenib and cetuximab, or encorafenib and binimetinib, which is a MEK inhibitor, or investigator's choice, which could have included irinotecan monotherapy, or cetuximab, or FOLFIRI and cetuximab. So the median overall survival improved from roughly 6 months to 9 months with encorafenib and cetuximab compared to chemotherapy. There was a response rate of about 20%, which mirrors the phase 1b results, and there was no additional benefit of adding the binimetinib with identical overall survival results. Guys, I find this really interesting to see how BRAF inhibitors are incorporated into early lines of therapy, and it's also important to note that we will still reach for immunotherapy first in these patients with MSI high and BRAF mutations. I think there's still a lot of work to be done, and Vivek, you had pointed out last time that these right-sided tumors that are more aggressive in nature tend to have these BRAF mutations, and so, it does beg the question, is BRAF a great target? I mean, it seems like the response rates are pretty low, but perhaps this is somehow resulting in a more aggressive disease, and I'm sure there are ongoing studies to better characterize this. I'm going to change the story just a little bit in light of our discussion so far. So let's say we had a young, fit patient, though, with a BRAF mutated, right-sided cancer. that is widely metastatic. So is there a role for upfront, more intensive regimens given the poor prognosis?
Yeah, this is a really great question. And this always comes up when we see young patients with metastatic disease, which, as in our early onset colorectal cancer episode that we had, we know is on the rise. So there was a study looking at the regimen FOLFOXIRI. So again, you're not throwing the kitchen sink. You have 5-FU, oxaliplatin, and irinotecan versus standard FOLFOX followed by FOLFIRI. And that study was called TRIBE-2. So patients were randomized to FOLFOXIRI plus bevacizumab followed by 5-FU plus bev maintenance and then retreatment with FOLFOXIRI at progression, or FOLFOX plus bevacizumab followed by 5-FU with bev maintenance and then switch to FOLFIRI at progression. So remember that older study that we had talked about that was done in the late 90s that really led to saying that you can do FOLFOX followed by FOLFIRI at progression and have good outcomes. In the study, there were 38% of the patients who with right-sided primary site and 10% of patients had a BRAF mutation, with the majority having synchronous metastatic disease, so this reflects a higher risk group of patients. Remember that metachronous disease means I was treated earlier and now I popped up with metastatic disease. So obviously that patient is very different than I have metastatic disease now and have mets at the same time, right? That's a higher risk patient. The median overall survival was improved from 22 months to 27 months, favoring the FOLFOXIRI arm. So we are getting a benefit in overall survival by 5 months, with many of these patients having higher risk disease. With that, though, there was significantly higher grade 3 and 4 adverse events in the FOLFOXIRI arm, including neuropathy, diarrhea, stomatitis, and neutropenia. Roughly 20% of patients who got FOLFOXIRI had grade 3 or 4 diarrhea compared to only 5% who got the standard chemotherapy arm that we've discussed about. And there were 8 treatment-related deaths with FOLFOXIRI compared to only 4 treatment-related deaths in the control arm. So patient selection here is very critical. And really, when we're looking at PFS2, it was really only about a 3-month benefit, and overall survival, we're looking at a 5-month benefit. And though these are meaningful, we have to choose the right patients to give this to. So really, we should be thinking about giving this to our patients who are younger and fit, and particularly those with BRAF mutated disease in the frontline setting, right? Because they're more likely to need more aggressive types of therapy. And ultimately, though, we should really be thinking smarter instead of harder for these patients, because now we do have these targeted agents, right? When this trial was done, we didn't have encorafenib and cetuximab in the second line. So it's not that every patient needs FOLFOXIRI, but it should be an option for our younger, more fit patient population.
And I just want to put that in context. You mentioned grade 3, grade 4 diarrhea. Remember, it only goes up to 5, and that's a fatal adverse event. So grade 4, that is life-threatening. That is hospitalization, IV fluids. Like, we're talking a very serious adverse event. So it's something you do not want to take lightly. You're absolutely right. So now let's finish our discussion with HER2-positive metastatic colorectal cancer. Remember, HER2 is another epidermal growth factor receptor that we've seen in other cancers, of course. So what therapies can we use for patients with HER2-positive colorectal cancer?
It's always a good reminder every time we hear HER2 to think about how we define HER2 positivity, because this always comes up on exams and this comes up in clinical practice. So we will link our old breast cancer episodes where we go into this in nitty gritty, but remember that HER2 positivity is defined as HER2 that's 3 plus by IHC, or HER2 that's 2 plus by IHC, and that's also positive on FISH testing. And again, check out those breast cancer episodes for a better discussion and a more thorough discussion on that. So there was earlier data looking at the combination of trastuzumab and pertuzumab in a basket trial of multiple tumor types that showed a response rate of roughly 30% of patients with metastatic colorectal cancer. So people certainly noticed that there was this response rate, and that ultimately led to the phase 2 Mountaineer study that was published in 2023, looking at the role of trastuzumab and tucatinib for patients with chemotherapy refractory metastatic colorectal cancer. So in total, 117 patients were enrolled, and there was randomization to doublet therapy or tucatinib alone. The objective response rate was 38%, and there were 3 patients with CR, which led to the approval of this combination in later lines. Just a reminder, though, that the long-term data on this is still pending, and we will link the phase 2 study in our show notes. What about some of the other agents? So, we've also talked about antibody drug conjugates in the breast cancer space. Has there been any data looking into their use for colorectal cancer?
We have this big antibody drug conjugate that's worked really, really well in breast cancer called trastuzumab deruxtecan, also known as Enhertu. And remember, in the metastatic breast cancer series, we talked about how that was a huge blockbuster improvement in survival for women with HER2-positive metastatic breast cancer. What's really been thought about with this HER2-directed antibody drug conjugate is you don't need a significant amount of overexpression of HER2. You can have something called HER2 low or HER2 ultra low and still get good responses and potentially improve overall survival in women with breast cancer who may traditionally be considered HER2 negative, right? They may have ER/PR positive disease and have HER2 low disease and still have good response rate. So there's a phase 2 study called Destiny CRC01, and this included 73 patients with any HER2 positivity who had metastatic colorectal cancer that was chemotherapy refractory. Patients were included then if they were HER2 positive by the conventional testing that Ronak had mentioned, or if they were HER2 low, meaning HER2 2+ by IHC with negative FISH, or HER2 1+ by IHC. Interestingly, no HER2 low patients responded at all. The drug was only active if they had conventional HER2 positivity by IHC or FISH. And in that patient population, the overall response rate was almost 50%, with a median progression-free survival of 7 months. And notably, nearly 30 to 40% of those patients had prior HER2-directed therapies. So again, it's really showing that there's really promising activity for those with true HER2 overexpression in colorectal cancer. And again, the overall response rate was 0% in HER2 low tumors. So we can't extrapolate the breast cancer data to our colon cancer patients, but this is a pretty big improvement when we think about targeted therapies in a very difficult patient population to treat. And we do know that HER2 positivity is rare in colorectal cancer, but that doesn't mean we shouldn't look for it. It's critical that we're looking for all of these things because of the improvements that we've made, whether they're incremental or big with the immunotherapy and the MSI high patients. We've still made improvements, and it's essential to get this testing in your patients. It's important that you talk to your pathologist and figure out how this testing's done. Do you need to do it through next generation sequencing? Or is this something that you're going to send individual tests at a time? And we're a very critical juncture now where the treatment for metastatic patients is evolving.
Guys, I thought that was a fantastic discussion today. And I think it really highlights just the progress that we've made in a disease that used to carry really terrible outcomes for patients. I think the big things to remember from today, it's really, really important to have certain additional testing available for our patients with metastatic colorectal cancer to look at all the opportunities for treatment options for these patients. So this includes their MSI or their MMR status. You also want to know their BRAF status, and you want to know their HER2 status on top of all the other information that we like to know about our patients. Remember that patients that have MSI high or MMR deficient positivity are able to be candidates for immunotherapy. And so this includes options for pembrolizumab, as well as data in the Checkmate study that we discussed for ipi/nivo in the first-line setting.
For patients with a BRAF mutation, currently we still want to start out with conventional chemotherapy, either FOLFOXIRI plus minus bevacizumab and 5-FU maintenance. But at progression in the second line, we can use encorafenib and cetuximab. We have data to support that practice now as well. So there is still a targeted therapy option with response rates around 20%.
And lastly, we have our HER2-directed therapies. Remember, HER2 low is not the same in colorectal cancer. We're talking about conventional HER2 positivity by IHC or FISH. And we have trastuzumab plus tucatinib based on that Mountaineer study with an objective response rate close to 40%. And these, again, are in chemo-refractory patients, so we look forward to seeing them push this up into earlier lines of therapy. And then lastly, we have that antibody-drug conjugate, trastuzumab deruxtecan. And again, it worked in the HER2-positive patients with a response rate of almost 50%. So excited to also see where that drug fits in earlier lines of therapy.
Great recap, guys. Well, I think that wraps up another fantastic episode of the Fellow on Call. Until next time, we'll see you all later.
See you later.
Peace.